2005, FDA came up with these treatments, the GLP-1 therapies, really to treat type 2 diabetes. We are now in a place in the world where we have over 1 billion people affected with cases of obesity. In 2024, there were 3.7 million obesity-related deaths from non-communicable diseases, meaning infection, which represented 12% of all deaths. The global costs, we don't think about costs often of being sick or overweight or having certain comorbidities, but global costs are predicted to at $3 trillion in the US by 2030. And this is in a country where obesity prevalence rates are 30% of the disease, really could absorb up to 18% of the national health expenditure. So, we're in a place now, and I believe that number where, it's $3 trillion by 2030, it's supposed to go double that by even beyond that. So this is a real issue to have obese human beings, if you're going by the obese definition, right, in terms of body mass index. But independently of that, research, as you mentioned, is now looking at obstructive sleep apnea, peripheral vascular disease, neurodegenerative diseases, and I will say autoimmune diseases, because I'm even seeing patients being treated as, my autoimmune disease patients who are on these drugs for other reasons that many, not all, but many are improving with their autoimmune disease symptoms. So I think it's a really interesting time, but who should not be on these drugs, Ashley? I mean, we think about how rah-rah everyone's running in to get these, and we'll get talking about kids being on these now, and for pets, and for people trying to lose 10 pounds for their kid's wedding. I mean, that's a separate issue. But in general, who should not be on these drugs?
The key thing with the drugs is no one should go on the drug thinking it's a solution. So you don't go on the drug and it doesn't fix everything. And more importantly, if you go on the medication and there is any benefit, so you lose some weight, or you sleep a little bit better, or a lot better, or you reduce your alcohol intake, I had somebody tell me, she's like, I think the agonist makes me like my mother-in-law better. I was like, okay, maybe, or maybe honestly, because your brain isn't so focused on your food thoughts, that was something they used to fight a lot about. And so now we joke about it, but it's really interesting. She's like, I had a great Thanksgiving, and it was the first, on that part. And I was like, okay. So if you have any success, you've proven my thesis, which is that you had suboptimally functioning of your own weight health hormone. So understand that our own hormones stay on for 2 to 5 minutes. And in that time period, they're supposed to go to all of these different receptor sites and land there in enough quantity. So the medications stay on the first one stayed on for 24 hours a day, and now they're staying on 24 hours for a week. So solid. So on that part. So think of an electricity bill. If you had a motion detector in front of your house or a light by your bed, and you put it on for 2 to 5 minutes, and it goes on maybe 5 times in the day, that's going to, or 6 times, it's going to be 30 minutes worth of an electrical bill. But let's say you leave town and you left a light on and you come back a week later, your electrical bill is going to be a lot more significant because you would have had it on that entire time. So the reason this is so important is that when we leave our lights on for that amount of time, when the medication does that, it's doing many amazing things by meaning that we're getting this ingredient directly to the receptor sites. It doesn't have to do anything in our body to be turned on, to be deployed, to get there. It's going right to the receptor sites and it's satisfying it. But it's also keeping you on for that whole time. So one of the places where there's an issue is that we are seeing people not get into rest and digest. We're seeing people, I've even had people who have told me that, caffeine is really hard for me. They're like, my coffee, I'm really wired now when I have coffee and I'm on this. And I was like, yeah, because your body has been metabolically active overnight. It's been telling insulin to go to work. It's been telling, ghrelin or leptin to go to work, et cetera. So that's one place. The second part is, and the other place that's dissimilar is, it's keeping your body in a delay of gastric emptying for that entire time. So many people are constipated. Many people are having reflux symptoms. Many people are having food get into the colon in an undigested form. And as a result, that can lead to things like SIBO and other, gut bacteria imbalances, et cetera. So the person who shouldn't go on this is anyone who's just I'm going to take this and I'm not going to do anything different. Now, you could say, I've been trying all these other things. I've been leaning into diet and exercise, and now I want to use this as well. I think the other thing is it's less about going on or off of this. It's also about how much are you using, because the lower dose and being able to use it to stimulate some of this in my work has done better than just, escalating people up, to a higher dose.
Are you talking about microdosing? Is that what you're
I'm so glad that you asked.
And what does that actually mean? Thank you.
Yeah. So microdosing is a bad marketing term, but I've lost the battle because all the marketing has glommed onto the idea of microdosing. I want to explain. Microdosing, for some reason, makes people, where in a society that has weight bias, makes people who have weight health issues feel better and makes other practitioners and everybody else feel better about using something that they call a microdose, because it sounds more like the peptide, biohacking, like I'm just going to microdose. A microdose would be a microscopic dose. That is not what people are using. And a colleague of ours, Dr. Tina Moore, I quote her in the book, this is her early work, demonstrated very clearly that a true microdose is not what we use for weight health. It may be used specifically for inflammation. It may be used for targeted things, but usually we use that in someone where we already have a degree of metabolic or a degree of weight health. So what we're really talking about here is a low dose. And the other part of it is we're also talking about not escalating the dose. We're talking about not following a pharmaceutical research studies that just said the first 6 to 8 weeks you do this, then you go up, and then you go up, because it's an ecosystem. And as you go up, we're throwing more and more things, off out of balance. So that's number one. Number two, the person who shouldn't go on the medication is the person who hasn't had an overall budgeting and access conversation. And this is regardless if you're a billionaire. I've had this conversation with you, true story. And if you are somebody who is struggling with access to either the medication or to things like your food choices and others, it's also a factor. But you do really need to personalize your nutrition and your lifestyle in collaboration with this medication. And the other part is you need to be able to do that ongoing, so that like after 3 months, if you've lost body fat, maybe we need to change your medications. Maybe we need to shift your food choices, and other things. And the second piece of that is I have a lot of people who didn't do the budgeting conversation, are paying out of pocket, and then are just like, oh man, I can't afford this month. So I have a lot of people who are like 1 month taking it and then 3 months not taking it, or, whatever. And now you're using it like a yo-yo diet. And that's going to be really problematic for your body.
Can you create a problem by on and off, like you can in certain autoimmune diseases where you become resistant to its benefits?
It's less about becoming resistant to its benefits. It's that you're continuing to create such a degree of irritation and you're driving some more suboptimal function. And so as a result, what you're probably doing there, because I've plenty of people in the peptide world that are like, I like to cycle GLP-1. Okay, if you know what you're doing, and you might be able to do that part. But if you're coming in and using it, and it's regulating certain choices for a month, and then you're coming off of it, and those are dysregulated. So one of the things to understand is, there's the reason I said if you see it as a solution, if you use this medication, it is suppressing or stopping your body's own production, because the receptor sites are satisfied. So it means like if I needed GLP-1 on my tongue, I have two ways of doing that. I can inject myself and have it go right to my tongue, or I can stimulate food. I can eat food. I can have it be stimulated. I can have the vagus nerve carry a message down. I can have the L cell release it. I can have it come back up by way of the vagus nerve again, and I can have it come back to that receptor site. So when we're on the medication, our own system is off. So anyone that thinks it's like this, oh, well, if you go on the medication, you have to stay on it for life. You do, absolutely, if you don't fix anything underneath, right? And on the flip side, if you go on and off, or if you immediately have to go off. So I had a patient who was on the medication, she got pregnant, and we wanted her off it. I don't have any data about during pregnancy. There's mixed feelings. Like I talked to her practitioner. She also a higher risk pregnancy. So it was like actually amazing. And so we're like, okay, we're going to pretty much just stop this right now. And we stopped it, but we had to walk through, like, I mean, literally on a daily basis, we were checking in on certain things to make sure she was able, and we didn't want her to all of a sudden gain a bunch of weight, during her pregnancy. We're like, how do we want to be thoughtful about how you gain weight during the pregnancy, et cetera. So we had to work on that. I've had a patient who was diagnosed with cancer while on the medication, not related to the medication. I want to be very clear about that. They'd been following something. We all knew this was the potential. And then it was, there's the cancer. And I think, honestly, being on the medication had been really helpful for them. Like, they'd stopped drinking alcohol. They were making better choices. We were really leaning into nutrition. But as soon as we had to go through cancer treatment, I can't have you on the medication. We don't have any of that information now. So we had to take that person off. And so what I want to be clear about is, like, this is a very serious thing when you come off of it. Just like if you're on a proton pump inhibitor suppressing acid and you come off of it, you can get an acid backwash that sends you to the hospital. You think that you're having a heart attack. Or if you're on a statin and then you just decide to stop your statin, your cholesterol is just going to go back up on that person. So what we do need, and to go to your original question, is who should be on or who should be off this. The person that should be on it, whether you buy it online or you don't, needs to be someone who is working with a team and definitely a qualified nutrition professional to help them manage all of these different pieces. Yeah. And that's really it, in my opinion, of who shouldn't be using the medication.
Yeah. So basically, you're saying that if you're going to get involved, you really want to be thinking holistically about your health and take it very seriously. And if you can afford and you have access to support systems, nutritionists, people who are really involved and understand the process of how these drugs work, and also what humans need anyway in terms of nutrition and hydration, and need to watch their bowels and making sure they're moving so that we don't have more problems.